the Littleton Board of Health Wednesday, May 19th Zoom meeting. Tonight is a COVID update and some discussions regarding the board. So, Jim, if you wouldn't mind starting us off.
Sure. So I had provided Mike with some numbers earlier, but just to kind of put things in perspectives, the last 2-week rolling number that the state reports, or the cases reported from the state, was 11. And the last full week, so the week for me ends on the 8th. We had 7 cases that week. So far this week, which would end, I'm sorry. Yeah, so for the cases, so far we only have 1 case this week. And there's only 2 more days left of the week. So the numbers look like they're all trending in the right direction.
Great.
State-wise is about, just shy of 13,000 estimated active cases in the state. So again, numbers that seem to keep going down, which is nice, along with positivity rate. I know Katrina will go much more into that with her report. Probably the biggest thing that happened was kind of the quickened pace of the end of the emergency, state of emergency, if you will. So on the 29th, lots and lots and lots of things change. It's almost easier to say what won't change than what will. So just to kind of give you an idea, the mask order will be rescinded. There will be places where masks will still be required. So again, like everything, we'll have to see what the new standards are. But right now, with the rescinding of the mask order, mask covering requirements will be in certain locations on public and private transportation, inside public schools, collaboratives, and approved special education schools, inside childcare programs and healthcare facilities and providers' offices, in congregate care settings, and in healthcare and rehabilitation day services and programs. So it'll be that group of businesses, if you will, that will still require masking. Industry restrictions, again, will be rescinded on the 29th, and capacities will go back to 100%. Sports guidance changed a little bit this week. Changes we received on the 17th that went into effect on the 18th. And probably the biggest change there was to allow kids, essentially kids, to not have to wear masks when they're playing sports outdoors. And so the guidance has been updated. 18 and unders don't need to wear masks if they're actively engaged in play. 19 and above still need to wear masks. So why they split it at 19, again, I don't know if they're trying to capture adult leagues. But we've had some questions from some schools around the fact that they have some high schoolers that are 19 and how that might affect them. So, my take on that is that if they're in high school and they're engaged in high school play, treat them as a high schooler for the school's purposes. What complicates this, and I'm not familiar with MIAA, I think it is, the School Sports League Association that governs school sports. They, I believe, adopt all of Department of Public Health, or I should say Executive Office of Environmental Affairs guidance, but it sounds like there may be some slight differences when it comes to like spectators and the way people are. I don't think the EEA document is worded very well, and I'm not the only one based on the Department of Public Health call, but I think the conclusion is that spectators at outdoor games, as long as they can maintain the social distancing, can be maskless also. So those are kind of the updates. Department of Early and Secondary Education has a series, put out a new question and answer for the public. Again, kids outdoor recess don't have to wear a mask. And the other thing that always from public health official wise makes us a little antsy is that if at recess, kids are less than 6 feet apart and one of the kids tests positive, they're not considered close contacts outside. So again, that's not how we at the health department apply it to most situations, but that's how the guidance is for Department of Early and Secondary Education. Cleaning seems to be the other big thing. Most of the workplace sector-specific standards backed off of it the last time they were updated. DESE has in their FAQ talking about frequently what they should be doing for cleaning surfaces. And again, the new thinking seems to be that surfaces are less a concern, and so more normal type cleaning it would be in place unless there's a reason to think otherwise, if they're soiled or somebody's tested positive. So again, those things have probably helped. They also talk about students being able to share objects. For a while that wasn't allowed. That seems to be allowed now also. And then probably the next biggest deadline is the 15th of June. And from the 29th to the 15th of June, I guess the best way I can read it right from the governor's press release, during this period of time, the state wants to work with municipal partners to transition from the emergency orders, measures adopted in the executive orders and special legislation. So all of the orders and whatnot that they put in place, they need to kind of walk those back and do that in conjunction with municipalities. You know, one of the biggest ones I've seen in the Department of Public Health's calls was around meetings and whether, you know, virtual meetings may still be allowed or whether you're going back to in-person meetings. So those are things as they work, you know, work back the governor's orders and executive orders and the state legislation. They need to work with the towns in the state to figure out how they're going to do that. So I don't know if anyone has any questions.
I have a couple.
May I?
How's your vaccine clinic going?
Very slow. We think we're reaching saturation point where we've asked the state to see if we can get some Pfizer, see if that might help out with vaccinating children. But yeah, low numbers, the 40s both days that we're over there.
Okay. Couple of questions. It's no longer it's not going to be a mask mandate anymore. It's going to be a mask advisory.
Advisory, yeah. So that there is, again, there's certain places where masks will be required, but otherwise the state will be under a mask advisory.
And so that's also up to a person's own personal protect what they want to wear. If they want to wear it, they can too.
But that's, yeah, I mean, you always have the right to wear the mask if you want to. Mm-hmm. We've gotten some of those questions with some of the individuals who operate sport, like presidents of sports league, you know, whether they could require something, you know, something other than. And what I've explained to them, it's these standards. I've got like 5 different sheets of documents on that because that's what it is. You have to really read these things when you. I said, you know, to have the league have something different than this, it would be. I think my advice to them is, because they're all volunteers and trying to maintain the leagues, is that we're going to follow state and federal guidance and standards as they exist, and that if people want to do something above and beyond, that the leagues will certainly respect the wishes of those persons to do that. I think it would be confusing to have yet another layer of. They're welcome to do it, but again, it's one of these things. How do you try to maintain that with volunteers and then volunteers then have to try to defend why they're doing something other than the state and federal requirements.
What are the requirements for municipal employees inside municipal facilities, such as Littleton Town Hall or wherever?
It would be my understanding as of the 29th, after that, they'd be able to not have masks on. So, for example, the town hall would have been covered by the office workplace safety standards. Those will be rescinded. Those standards will be rescinded. So I hate to use the word, we're back to normal.
So do you think it's worthwhile to communicate that to the folks who run Littleton's operations in town hall?
Yes, I mean, that certainly can, we have conversations. And my understanding, there was a meeting in town hall. Scott, maybe you have more information about that, about what you might be doing after that.
So if you want to put a mask on, you go to the town hall and they say no need to. But if you wanted to keep your mask, well, nobody will give you any problem.
There shouldn't be any issues if you want to wear it.
If you're already being vaccinated, I'm sure that somebody's concerned. If everybody that goes to the town hall already had the vaccine, if somebody doesn't have it, then he should wear a mask, even if he doesn't like to put it on. Am I correct?
Well, that would be the nature of the advisory.
And another thing, Jimmy, I was wondering, because I'm in Rotary. In July 15th, there's going to be a triathlon. How many people can they be there at the lake? They're limited right now, or they will be allowed to be there as many as they can put?
In my understanding, if all of these are rescinded, then there's no restrictions.
No restriction. Well, thank you so much.
Yep.
Thank you for what you're doing. Thank you.
The other question that I had, Jim, you can take your mask off with proof of that you've been vaccinated, but there's not going to be any way to enforce that.
No, I think that's why we have, why they were sending it, and that's why it's an advisory, because it would almost, it'd be, I mean, I don't know, do you wear your vaccine card around your neck so that people don't question you? I mean, it's, and part of it is it partially an incentive to get people to get vaccinated? Is it partially kind of a nod to those people who chose to go get vaccinated to protect others? Are we still hopefully going to be doing some social distancing regardless of the fact that all of these things are lifted? Will some people still wear masks? So, I mean, I think there's a lot that come into play. And I think once the CDC came out with what they said, I think it probably made it difficult for all the states to do something that much more restrictive.
Okay. Does anybody have any questions for Jim?
I have a quick one. I'm hoping, Jim, probably your public health nurses may know better. We're not quite out the other side of this, but kind of thinking after action report, kind of root cause analysis, what can we learn? We certainly remained red beyond the time of our neighboring towns by a couple of weeks, and we were still yellow when the neighboring towns were green or gray. It's probably from a contact tracing piece. Were we able to identify any trends that made Littleton's population different than our neighbors who are probably closest demographics to us? What was different in Littleton over the last 3 weeks that has kept us with a higher rate? And is there anything we can do moving forward, or because it'll come around again at some point in the next 5, 10, 20 years, that we can identify to kind of early intervention, early targeting of education or actions? Have you identified anything from contact tracing?
So that last 3 weeks, Mike, at the last meeting, Mike had asked me to take a kind of a look back on the cases for the past month. And what I noted was in those the weeks where you seem to bump back up again, because the numbers were headed down, they were lower. There were just a handful of addresses with a lot of cases at each address, which really kind of spiked the number back up again. And so other than that, as I look through the occupations, as I look through where people were, as I look through travel, there didn't seem to be anything that there was only one mention of a party, but that only was connected with a couple of cases. And so, I mean, there wasn't really anything, and it sounds like a cop-out thing, but maybe the town, lots of people are moving lots of places, which increases your probability of coming into contact with somebody who has a case of it. And with enough asymptomatic cases out there, between that and those handful of addresses where there was lots of cases per address, I think that's what near the end kind of popped it right up.
Okay, just trying to figure out. My guess is, all the towns around us are kind of in that same boat of just seeing if there was any kind of low-hanging fruit of why did we have the couple addresses that popped up with full families bumping our numbers, and Acton or Air or Groton didn't have those same kind of events. So I was just curious if we identify early for the next time.
Sure. Well, I think, let's say this comes around again, I think, just based on this whole year of contact tracing, families were the biggest source of clusters. And so trying to figure that out, trying to, message to families, and it may be that it's too late by the time but trying to get people to separate in households and strictly separate to try to minimize the number of cases that went through the house. That to me is the biggest part. And I don't know if there was like a stigma with it that people wouldn't want to say, but my thought is, I would always approach it to people that says, you just don't know that person in front. You just don't know if they have it or not, because they may not know it until they lost their sense of smell or they had some dry cough or something. And so it kind of snuck up on people. And if you were asymptomatic until you had a reason to go get tested. I mean, so to me, that's the tricky part.
All right, cool. Thank you. I figured I'd ask.
Sure.
And I'm getting some text. I think Katrina might have a question for you, Jim.
Okay.
Katrina, go ahead. Did you have a question for Jim?
Normally I'm on the panel, so I'm very confused tonight. I'm not sure I can share my slides later if I'm not on the panel. But so Jim, thank you for covering all that. I have kind of a response I want to add to Dan's question, if it's okay. The other thing that I think was holding Littleton onto the red a little longer was that we were classified as an under 10,000 population level, which then went strictly by case numbers, not rate plus test positivity. And so that every time we came down, we were always like a week behind everywhere else. And this one, it just, the timing with those large households held us for another couple of weeks. So the other piece of that is that we were almost at 10,000. So we're one of the biggest cities in that block, if you will. And so unfortunately that didn't help us in that situation. Because when you looked at our test positivity at the same exact time, if we were any of our surrounding communities, we would have been yellow. So that, I know everyone's kind of frustrated by that situation, unfortunately. And then, Jim, I did have a question for you. When you described close contacts for outdoor recess,
Yep.
has the state changed the definition of close contacts for like sports or youth activities, the EEA?
No. So statewide, the definition for close contact hasn't changed, but there's this, and again, this is personal, so that's not a reflection. There seems to be this cutout for DESE and schools, and I'm not sure how they work with the Department of Public Health, but often they, when they reference something they're doing, it's always, and I'll read you the language, after consultation with the Mass COVID Command Center and the Medical Advisory Board. I would assume that's the same group the Department of Public Health's messaging with, but DESE seems to have standards that I don't know how they arrive at, and they seem to be a little different. So, the first one was when the kids could sit, the 3 to 6 foot wasn't considered a close contact inside schools. That was the first time we kind of went, okay. And so I guess I'm not surprised in an outdoor setting that's how that's changed.
Yeah, I guess given the pooled testing for schools has been great across the state, I'm less concerned about that close contact definition in the school setting and for recess, because they're being highly monitored and people are pretty well trained at this point. Yeah. So I was just wondering if that had also changed for youth sports, given that they were allowed maskless outside.
No. And when I'm talking to youth sports folks, I'm telling them, still try to keep the kids 6 feet away from each other on the benches when they're on the sidelines. I said, that's, for me, it's sports. It's always been coming and going, how they're getting there, how they're going home, what they're doing when they get there. Because, the guidance is always talking about making sure that you're coming to play and then leaving, because those gatherings, I've been to enough youth sports games to realize that the spectators often come to socialize, and that's not a bad thing, except in COVID, you want to try to keep them apart. So those have always been the concerns for us with sports teams. So if they, and any of the league presidents, whether it's soccer or baseball or whatnot, they all seem to really have internalized that, and they have their own ways of, whether it's they have kids hang on fence posts because they know the posts are 10 feet apart, or they have some mechanism by which they keep the kids apart.
Yeah, there's definitely, I have to say, the youth sports my kids are involved in, there's definitely messaging about it coming out. So that's actually good to help that out. Thank you.
Yep.
I'm going to log out because for some reason I'm still not promoted, and see if I can log back in and get back in.
Katrina, you don't have to log out. I'll make you a panelist.
Okay, great.
Okay.
Does anybody have any other questions for Jim? Because I think he has to take off. No. All right, Jim.
Ready. Thanks. Good to
Thanks
see
very
you all.
much.
Nice.
Thank you.
Thanks, Jim.
All right. So Katrina, do you have enough to talk about tonight?
I do. I just used yesterday's stats, which left out there's one piece that I need, but I'll talk about it when I get there. All right. Making sure I share the right thing. You guys are seeing my first slide, correct?
Yes.
There's a lot of things open. All right. So when we look at the state, we've got these 4 trends. They've definitely trended in the right direction, but we'll zoom in a little closer. When we look at tests, we've talked about over the last 3 weeks now that tests seem to be going down. And given the high rates of vaccination in our state, that's actually probably understandable. And the redefinition of who a close contact is for schools has probably also helped depress the number of tests being conducted. So fewer cases means fewer close contacts, and that means fewer tests being conducted. So we're hoping this is a positive feedback loop. And then when we look at test positivity, it's trending lower as well. So we're at just over 1% this week. Last week, we were at 1.25%. So as a state, we continue to trend down. And the test positivity by age group is flat. So that hasn't really changed. Okay, so the number of cases continues to trend down. We've been this way for 6 weeks now. We now have every day, we have about 480 cases reported a day on average. The 14-day incidence rate declined slightly this week. It was 12.8 last week per 100,000, and it's 12.5 this week per 100,000. When you think of exponential decline, like decay, we're at the point where there's just not, that is still exponential decay, it's just slowing down. That's what you're supposed to see. So don't freak out that we're not to zero. It will take us a while to get there. So unfortunately, this case rates by age group is the piece that has not been updated, and I can't get from yet. They release it every Wednesday, and for some reason, every Wednesday they delay the posting. So last week, the age 15 to 19 continued to have the highest rates, followed by 10 to 14, and then age 5 to 9, and those are largely unvaccinated age groups, so that makes sense. Where we also saw really great improvements in the 20 to 29 and older age groups over time. So we're trending in the right direction for vaccinated groups, and it was flat for unvaccinated groups, and I really wanted to see which way it was going to go this week. So I will have to update you later this week.
Are you still presenting to school committee still?
I am presenting tomorrow. I've been asked to present tomorrow to the new school committee board.
Okay.
So I will hopefully have that data and can include it in that presentation, and then I will send you guys an email so you have an update.
Perfect, thank you.
And then we continue to see the hospital rates decline, which is also a really great sign. The average age of hospitalized patients actually declined from 61 a couple weeks ago to 55. So again, those impact of vaccinations in those older, more at risk for severe outcomes age groups. We want that number to go down. We don't want young people to get it, but hopefully eventually we're going to hit a low number for that. So the hospitalization rates are now about 430 patients in the hospital each day. And this week, hospital occupancy declined as well. So it's now around 80% of hospital beds are occupied and 68% of ICU beds. Last week, that was 75% for ICU beds. So this is another wonderful sign that we're going in the right direction. And then the 7-day average for confirmed deaths remains low, and with a 7-day average similar to last week. So we're around 7 to 8 deaths reported a day, which is where we were in June of last year, which is great. And then vaccines continue to roll out, although the pace of the rollout has slowed over the last week or so, because the last group became eligible, 16 plus. That last phase group became eligible April 19th. So those people are starting to hit fully vaccinated status right about now. And then the 12 to 15-year-olds were opened up last week. So we should have an uptick in vaccinations with that group starting to get vaccinated. So hopefully we see that next week's or tomorrow's data. So then let's look at Littleton. So this is, again, the DPH report for last Thursday. Littleton last week had 17 cases for the 2-week period ending May 8th, as Jim described. There was a nice drop from 30 cases the 2 weeks prior, when those households that he noted had fallen off the 2-week rolling average. So last week we were back in the yellow. That was a nice drop. And we were like, we've had that drop and then bounce right back up, and we weren't sure what was going to happen. So when we looked at our trends by age group, wrong thing I'm looking at. When we look at our daily incidence rate per 100,000 for the 14-day period for all of the areas that we have been following, Littleton's rate last week was 12.4 per 100,000, and that was a drop similar to the level of where the state was, 12.5 per 100,000. So we went from that high level where we were higher than everyone, and we finally caught up to the state average, which is great. The state, the county, and the surrounding areas that we track all trended lower week over week for 6 weeks. So this is another wonderful trend. As people started getting vaccinated, our trends started coming down. And when I look at these rates, these are similar to what infectious disease experts are aiming. They're aiming for less than 5 per 100,000 to really suppress spread and to be like make it really hard to have outbreaks. Less than 5 cases per 100,000 per day, and the same value for hospitalizations. So we're really close to that for hospitalizations if we're not there now. And at 12.4 for Littleton and 12.5 for the state, we are a couple of weeks away from hitting that level in our state. So hopefully we can keep this going down over a few more weeks, even as things reopen. Test positivity as of last Thursday, Littleton had 1.81%, and that was down from 2.37% the 2 weeks prior to that. So we were finally trending back down after that, that little surge we had. And the test positivity for all the areas we tracked declined over the last 6 weeks too. So we've got test positivity and cases declining in the same manner, the same pattern, which is a great thing to see. So this is, let's look at where we were going. This is the Maven sneak peek that Jim does for us, which is so helpful. So for the period of May 2nd to May 15th, Jim counted 11 cases in Littleton in that 2-week time period. And that puts us, hopefully when the report's released tomorrow, in the green, which will be amazing. And actually very close to the gray, which they just can't report less than 10 cases. So basically anything from, I think it's 15 cases lower is green. We're doing well. So this is, again, like that excellent thing to see, and the significant reduction of cases over the last few weeks have actually corresponded to our really increase in vaccinations. So, and we haven't seen this case count this low since just before Halloween. So here's the health notification letters for the school. And I have to say, everyone last week, we got 5 letters last week, and it was, everyone kind of gritted their teeth, because up until last week, every time we had a case in the school, there was household transmission and somebody else at home that became a case. So it was like, okay, we got 6 this week in the schools, multiply by 2.5, our rough estimate's going to be, you do the math. And we received one other notification on Monday, and those actually aligned very well to the numbers that Jim reported for the week over week average, or week over week counts. So essentially, if we put these two pieces of information together, it seems that the cases that are being discovered and reported are unvaccinated age groups. So kids who are at much lower risk for severe outcomes and things. So again, our vaccinations are working, and that's a great sign. So when you look at it by the each school, it's also spread over the 3 schools where the majority of the students are not eligible for vaccines yet. So we had 3, counting the one this Monday, 3 at Shaker Lane, 2 at Russell Street, and 1 at the middle school. So that matchup, this is another sign that our vaccinations are doing the job. And then hopefully if we can get our rates low, under that 5, then we'll start protecting those kids too, which is why there's still mitigation, especially indoor environments for kids. And then the other thing that was good news is that pool testing continues to have 0 positive pools. Week over week, we haven't found one in the school. So that's a really good sign that does not seem to be in-school transmission happening. So that is actually a really, the school's continuing pool testing through the end of the year. So as the school committee will consider what to do about recess tomorrow and masks, I know that's on their agenda. So depending on what they decide, they have pool testing. If they change the policy, they have pool testing to track the impact of that policy. So this pool testing is a great tool for us to learn about what's happening so that maybe we can apply these lessons to the fall. And then the schools are working on a COVID dashboard to summarize the pool testing and the number of cases that come in so that it will be live on their website on an ongoing basis. And I believe Lynn Snow said they're going to introduce it tomorrow night. So I will send that link when I find it. All right, so this is our vaccination data, and this comes from that weekly vaccination report, which was released last Thursday. So we are now a week behind in this. Littleton has done an amazing job. We have about 67% of our residents have received at least one dose. The rate of increase, just like the state, has slowed over the last week or so, in part because anyone who was, as soon as they became eligible, there's that surge of people seeking vaccinations, and then it slows down. My guess is, seeing the number of Facebook and pictures shared of the 12 to 15 age group getting vaccinated this last week, that the numbers will pick up a little bit, especially in that younger age group. So that 0 to 19 age group is only 16% have received at least one dose, but that's because there's only 16 to 19 who's eligible. We hope that number will go up with the 12 to 15-year-olds next week. But then every other age group is over 70% had at least one dose. So the good news in our state is that most people are returning for the second dose if they need one. So we hope that will continue to follow for everyone. And then even males and females, males actually increased in percentage at 4 percentage points this week compared to females 2 percentage points. So that was a nice thing to see, that they're up to 65% now, and females are at 70%. And then I did do a quick look at the race and ethnicity data, and we know we are predominantly a white town here. And actually the number of people in Asian, Black, Hispanic, multi, or other categories is actually higher than our denominator that the state's using. So those are definitely great signs that we don't have an issue where we're missing certain groups of people who, where the state is concerned about it in other towns. So this is awesome. And again, high across the board. So we're doing really well with vaccinations. So I know last week I went through this concept of community immunity. I'm not going to go into it in detail now, but I want to revisit it real quick. So as we have more of these people, we have large numbers of people vaccinated, the more roadblocks we put up for the virus to not be able to cross, basically. And we're going to break these chains of transmission. So I'm going to throw this up here just to remind everyone. And then I tried to visually think about the vaccination percentages I showed you on that first slide in a way that makes it so you can understand how unvaccinated groups of people kind of cluster together and what that might mean for protecting people who are unvaccinated or unable to get vaccinated or immunocompromised and their vaccine doesn't work. Excuse me. Let me go back. Made it so I couldn't see it. All right, so when we think of the age to 0 to 19 group, clearly those 12 to 19 are the only ones eligible for vaccination in there. So the majority of this age group will remain unvaccinated, these gray boxes. Let me back up. Each one of these boxes represents 1% of our population. So, we have majority of this age group, which represents 24% of our population, who are not eligible for vaccination, and another 4% who just became eligible. So that will help boost us up, and another 4%, or not 4%, this other group here who's been vaccinated. So we're getting that group vaccinated, but if COVID's going to spread, it's going to spread among susceptible individuals who are either have not been sick or they have not had vaccine. And this group, that's why we need the mitigation strategies at the school. And if people can use them for activities and things and just keep watching yourself for a little longer, we'll be able to drive the rates down. But when you look at adults age 20 plus, the majority of our town has been vaccinated, which will really protect not only the people who've been vaccinated, but also help prevent spread among the unvaccinated groups in this age group. So you'll see groups of adults who are unvaccinated just by choice or lifestyle decisions. Groups with people with similarities tend to group together, who think alike group tend to get together. So we're going to find some groups that it's still possible that we'll have an outbreak, but it should be spreading among unvaccinated groups and not across the board like we were at risk of last December. And then So as Jim touched upon, the CDC guidance came out last Friday, I think Thursday, Friday. And the evidence has been mounting months over months now that vaccines not only protect people from severe COVID disease, but also prevent spread. So this is the time when the CDC said fully vaccinated people don't have to wear their masks, social distance, and can essentially go back to normal. However, with the exceptions of where that there's federal, state, local rules and regulations, including local businesses, what your Board of Health puts in place, workplace guidances, things like that. And so this is just a really great update. It means that our vaccines are working. Our state has high vaccinations. This is a good sign. Although I do have to note that it made people very uneasy and also made them celebrate. And it was about 50% on each side of those camps. So I guess they timed their release of these guidelines right. Because if you get half and half upset at you, then you pretty much probably hit the sweet spot in the middle. So the state followed up with what Jim described. So I won't go into this, but we are moving into the next phase, moving out of the COVID phase. So since we've had so many people vaccinated in our state, including 75% of all adults have been vaccinated, we're almost at 4.1 million residents vaccinated and expected to be there by the first week of June, which is a great target. So because these vaccines are safe and effective and we have done what we should do, which is get vaccinated when it's our turn, we get to start having the benefit of rolling back these restrictions. So it is still being stated by the state and the CDC that unvaccinated individuals are advised to continue to wear masks and to continue distancing in most settings, especially indoors in large crowded indoor and outdoor venues. So people who choose to be unvaccinated should continue to take care, or just aren't unable to be vaccinated. And then what I'm hearing now is the kids aren't vaccinated. So it's fine, everyone's gonna be fine, but there are still people who are at high risk for severe COVID. So as we move to this next phase, I think it's important to pause and be considerate and recognize that there remains individuals, unvaccinated and even vaccinated, who are at high risk and may need to take extra care. And so as we know, adults have higher risk of severe disease, but most adults can be vaccinated, and outside of immunocompromised individuals, the vaccines are really highly effective and safe. And so we hope people will continue to go seek vaccination to help protect themselves and their family. But children are largely not eligible for vaccination yet. And we know they are part of transmission trains, especially those kids 10 and above have been shown to be part of transmission chains. So if your kid's 12 and above, please get them vaccinated. If they're not, we still need to take care, because everyone knows, even a child with one of these risk factors. Everyone knows someone with asthma. Everyone knows someone with who's obese or overweight and or has some medically complex issues that need to be taken care of. So what you can do to help protect everyone is to get vaccinated. So if you're in a household with as somebody at severe risk, make sure everyone who's eligible is vaccinated, and then also talk to your doctor about your risk factors and what other precautions you might want to take, such as wearing masks when you're in public places, things like that. So those are just great conversations to have with your doctor so you can help do your risk, assess your risk. And then just be kind to others. You don't know their story, so just make sure that you just don't worry, And I'm going to keep coming back to this. This is my job at this point, is to say that vaccines are the solution. They're shown to be safe and effective, and they prevent spread. And this is our best protection from COVID, and to keep life open and to keep this feeling of things opening back up and changing in place. Because if things could happen again, and it might shut us back down, but hopefully our vaccines continue to be protective for us. And this is the best way to protect yourself, your community, and your family. And then the one last thing, I just want to do a little mental health reminder. With these two announcements that came out, you could see the reactions were across the board different from individuals. Some people were celebrating and others were completely upset. A lot of people were confused. Things are changing fast. Honestly, we all need time to process and readjust. So we've already started to see a variety of reactions to these announcements too. And even when it was just guidelines from the CDC, which weren't even state policy yet. So our mask order is still in place in many situations in Massachusetts. So, you know, you should still be wearing your mask right now until May 29th. And there are some people who will continue to wear their masks, whether they're in indoor settings or outdoor settings for the foreseeable future, especially when they're around large groups of people. There are businesses and workplaces that will ask you to mask. That's within their right to do. We will see kids wearing masks in places where they have been told they don't have to. And again, that's okay. Like adding a mask is never a bad thing. The science is behind that. So if a kid feels better with their mask on in a certain setting, they can wear their mask. So I do think it's important that parents and any role models for kids remind or help kids understand that people can choose to wear a mask or not in certain locations, and it's their choice, so that if they're wearing a mask and it's outdoors and whatnot, they don't accidentally hurt another friend's feelings or something like that. I think it would be unintentional, but it'd be great for us to help educate our kids and their peers. And there's just a wide range of reactions to all these changes, and that will come at us in the next month. And even within the medical and science community, there's been a wide range of reactions. And what I was thinking about is that this shift actually reveals that there's a wide range of behaviors and policy decisions that are actually consistent with the following the science phrase that keeps getting used a lot. So it'd be really wise to maybe back off on that phrase and just have conversations about why people, which part of the science are people following and prioritizing over others, and then having a real good discussion, especially when policy is being set. And the pandemic is not over worldwide. We know what's happening in India. There's other Asian countries are starting to see little upticks. The US is emerging from it now because we hit vaccines hard and fast, and because we had access to them. So at this point, the rest of the world has to catch up on vaccines. So we are in a great spot here, and just keep in mind that we want it to stay this way. So vaccines will crush COVID. I think that's going to be seen. We may have COVID with us for the foreseeable future, but at this point, it's really changing the way we will live our life over the next 4 weeks and beyond. But no one is immune to loss or stress and vulnerability during the pandemic too. So we've really experienced this collective trauma, and we're all processing it differently and coming out of it differently. So I really hope everyone can be supportive of one another and to give everyone the time they need to readjust their thoughts and their behaviors and their choices, and to let everyone start to heal from these experiences over the last year. This has been a hard year. We've got some work ahead of us in terms of mental health, but this is a nice moment to see, given where we were a year ago. So, it's done.
I just had one comment, and it may have something to do with the vaccines with the students, because the vaccines can sometimes have side effects. I know personally we waited until college classes were done because we were going through finals and presentations, and I didn't want him to be sick and me be blamed for it. So we waited. So this may be something that as colleges get done with, and public schools get done, we might see, you said, like an uptick in that as they get eligible, and as just so they don't have to deal with the side effects too. So
yeah, I definitely scheduled my 12-year-old's vaccine appointment so that it didn't hit on recital day, like her second one. So there's definitely people are planning when their shots are coming. The other thing about college kids coming home is that the federal so if a college kid had their first dose in another state, the federal government opened it up so that there's no more residency requirements for, I think Massachusetts is like this for all sites, but it would be good to look into first Maybe Jim can answer this at a future meeting, but I know that the pharmacies, because they get the supply from the federal government, they have to give second doses. So if somebody got their first dose in another state and still needs to finish their COVID the 2-shot sequence, then they can do that locally at a pharmacy.
Does anybody have any questions for Katrina? Great.
No questions. Thanks, Katrina.
Welcome.
All right. Great. And Scott, did you have anything to add for the COVID update this week?
Nothing of significance. I would say that townwide, obviously, it's great. The numbers are going down, and we've definitely noticed our transports of COVID patients have pretty much dropped off significantly. So even the people that are sick, they're not sick to the level that they were, obviously when the pandemic started. So it's a great thing. And, the guys are we still take those precautions, even when we do have the potential of positive patients. But other than that, things townwide appear to be somewhat normalizing across the town. The highways, people being out and about, everything is definitely coming back to a level of normalcy.
Mm-hmm. Because you're required to use the PPE, I would imagine. You're not, none of the state regulations have changed for you.
No, that's more of an internal policy. Anybody that we haven't changed our policies at this point. All patients still receive a mask, and we still wear our masks when we're inside with the patients, and they still do decon for all of that. So, as it eases up, that some of that might change, but I would say for the most part, we'll continue on with a level of that. Obviously depending on the status of the patient.
Great. And you have leftover PPE? Money?
We're pretty comfortable with PPE right now.
Good.
A little bit different than the beginning of the pandemic.
I know. Remember when they were having nurses wear bandanas, where they were recommending it? I'm like, oh my god. Anybody have any
Scott, a
questions?
question? Yeah, Scott.
Go ahead, Mike.
I'm just curious. Do you require your crews to be vaccinated? Is that a requirement, or have you sort of do it informally?
It has been opened up to all of the individuals, and some individuals have chosen not to for one reason or another. So it's a difficult situation. I can't mandate it.
All right. Any other questions at all? All right. So we'll move forward. Thank you, everybody, for joining us again tonight. And if you don't mind sending that email to Katrina with the final numbers when you see it tomorrow. Thank you. Thanks, Scott.
Thanks, Chief.
So we'll move on to the discussion of the paths forward for the Littleton Board of Health and how best to fulfill the needs of the town for public health. Did you have anything how you wanted to start this, Mike?
Yeah, I'll go through this as quick as I can.
This sounds like a Star Wars episode, The New Beginning.
Well, we're trying. Okay, so we're going to change gears. This is not about COVID. Mm-hmm. It's not about vaccines. This is a chance to take a deep breath and consider and discuss something else. As most of you know, a vote was taken by the Board of Health with support from many individuals around town and on boards that it was time to look at and to seriously consider and move toward having our own, as it were, board of, basically a public health department, given the, shall we say, the maturation and development of the town. So what I'm trying to do here is not to set policy or not to provide solutions, but to bring illumination to some of the issues that at least I had a chance to, as it were, take a look at and confront, frankly, during the course of trying to understand what was going on. And the idea here is to engage this board in a rather, shall we say, direct and serious way. There's a lot of work to be done on our part, and you'll see why, hopefully, within a short period of time tonight. So regardless of what you see here, except the bare bones, any suggestions that pop up about what we should be doing or not be doing, they are suggestions. They're not items for voting tonight. They're designed to stimulate discussion and consideration. All right. What we're going is we're trying to create, or we want to create, a Department of Public Health, frankly, to better serve the town of Littleton. Now, the very basic organization is set, fortunately for us, by law and regulation, and that is the Board of Health, as the big arrow pointing down by coincidence indicate that legally we are the ones who provide policy, direction, and control of a director or whoever is designated to be the health officer of the town. And traditionally, that person in turn takes direction. The sanitarian, if there is one, takes direction from that director. And I've left the issue of, and the, shall we say, the various ways in which the public health nurse function, which is an essential component of any public health effort, regardless of what configuration. I've left this open again for discussion. There's no question that, in technically speaking, the Board of Health, quote, would also have a direct, shall we say, supervisory responsibility for the public health nurse. However, from a functional point of view, it may emerge to be somewhat different later. And for a variety of reasons, which I'll be happy to explain or will explain in part, on the administrative side, we're going to get our support from a newly minted or about to be newly minted department called land use. That's going to be an administrative center, as far as we're concerned, that provide us and the director and the sanitarian and the public health nurse with administrative support. And that's the duties. We're going to have to establish, as it were, our criteria of what kind of data we need, how we're going to handle it. What the main take-home message is that we can work, of course, to be, in terms of technical things like software and how the data gets handled and all the rest, we can at least be consistent among a bunch of other departments and functions in town that have access to data that both ours and theirs that we find very useful and important. All right, so the first steps, and I'll bring up the data, what's on the warrant and where that is coming now for the June town meeting. The last time that the select board met to decide what was going on to it was basically, it was called Article 36 on the warrant. I don't know if all of you saw it. Basically what it does is it authorizes our transition out of the Neshoba Associated Board of Health. I'm sorry, Lisa?
It's Article 37.
Oh, it's moved already. All right, because something got dropped out. All right, good. All right, so it's there. And all that's happened here is that the authorization to terminate the relationship with the Neshoba operation is basically going to be voted on and more than likely approved at town meeting. This is an opportunity for us to take, and this can't be, the transition can't be done overnight. We have a long history of operating very differently. There are still pieces missing at town hall, including personnel, technical components. So there's going to be a transition period, and the transition period will give us an opportunity to basically sit down and really make an effort to understand very clearly what our elected board takes on as responsibilities for policies, direction, oversight, as well as its role in education, compliance, and adoption of needed regulations, rather than have basically a, shall we say, an uninformed picture of what's going on. This will give us an opportunity to basically come to an understanding of what it is, find out what is missing, which is not understood, and try to get it straightened out with the help of not just town council, but others at the state level. Our other thing is to get ready to select a team of well-qualified public health personnel to staff the department. And yes, there is a suggestion of where we should start doing that. During this period of transition, and I don't know if I have it explicitly on the next slide, I do, is that actually the transition as we have envisioned it to go to a real department requires on getting available funding from basically town meeting. And that's going to probably happen for us in the fall. So we have between now and the fall to get ourselves ready, because the door has been opened to provide the authorization to basically not have our connection with the Neshoba group. So that means that we've got to start moving on completing the transition. During the transition, the idea is to stay in. We also have the next year, the fiscal year we're entering. We've already made the commitment to the Neshoba group. And during that time, it's been agreed that should we bring someone in, a sanitarian or a director or whatever, that Jim has agreed that he will work and, shall we say, basically provide a very detailed experience to give the individual an opportunity to become familiar with what that individual will be looking at as the, shall we say, health officer. Now, I'm making a suggestion here, and I want to label it as a suggestion because we have other members of the Board of Health who may have different points of view. We have the time to go into detail and discuss this. The suggestion I have is, or the suggestion put forward, is to hire a director of public health. That is a senior public health professional with the necessary credentials and all the rest. That should be a recommendation to the select board and to the town, getting ready for the next town meeting we're going to have. And the reasons for this is that the sooner we have a professional, as the transition, as it proceeds, if it's another year, it's another year. It gives an opportunity for us to start working with a professional to build the department. All of us here have day jobs. I would suspect that Dan, even with his RN, is probably a busy individual during the course of the day. I'm not sure that he's got the time and the, shall we say, all the opportunities necessary to provide the kind of guidance that a professional public health director can provide in providing the vision that's needed for the town, asking the critical questions. I'd much rather have us, shall we say, have that individual respond to us in terms of our critical questions and have back and forth. I think once it becomes public that a health director or a health officer for the town has been, a professional one has put in place, I think it has a greater impact on public health awareness. The Board of Health has been basically in the shadows for years and years and years. Here's a change going on. Just the mere fact of a change is enough to get the public aware, oh, they're doing public health and they're taking it seriously. The other piece is that a public health professional is in a very, very good position to raise voice about the town's needs. This is not someone sitting on a board saying, oh, we need here, I want to make this up, for spousal abuse. I'm not saying it isn't an issue. I'm merely saying that here's an opportunity for someone can speak to major components to be taken seriously. And also, a very important reason, I believe the health director or health officer should have the major role in determining the recruitment of the nursing operation to make sure it stays professional, a professional choice, as well as the sanitarian. Okay, now, pathways to achieve our aim. First of all, we're going to have to work pretty hard. And what I mean by that is come to some understanding among ourselves, a consistent theme that defines and articulates the benefits by having a better public health service and environmental protection capability in place. There's going to be investment, and we have to make people understand there's an investment. Their tax dollars are going to have to be invested to require those benefits. We're going to have to involve all the public and all relevant boards, commissions, department, fire, police, an example. is the select board, the Department of Human Services, which is already trying to provide services in this area, Council on Aging, and the school committee. So it's going to be up to us to make it very clear why is it worth going in this direction? What the benefit is against the following. Now, here's the graphic that very frankly looks sort of stark until you give it just a 10 seconds of thought. This is the current yearly assessment that Littleton is paying this year for basically Jim and his crew at Neshoba. So it's about, rounding up, it's $40,000. I think you've seen this before. Nothing exciting here. Okay. What I have here is what I could extract out so far are the average salary ranges in Massachusetts for personnel of interest to us. The Director of Public Health, and this is independent of where, I mean, for obviously a town like Brookline, a town like Chelmsford, other towns may be paying less or more, but here's the range, somewhere between 87 to 120,000 a year. A sanitarian, anywhere between 54 to 65. Public health nurse between 46 to 60. And I'm using only one here. It's arbitrary. What's recommended by the CDC and the state of Massachusetts is one nurse per 5,000 population. I've reduced it to one, even though we're standing around 10,000 to get our discussion going to understanding how we're going to have to get into this issue of needs. All right, so let's see what the estimated cost is. What I've done here is taken the average of each of those categories, put them together, but I did not include the benefits because this has an impact on the town budget. The carrying cost for this, I don't know exactly what the, as it were, the indirect or benefit costs are associated with this. You can use figures like 20%, whatever you'd like. But the main thing about these costs are they're indefinite. They go on. They're part of the town budget. And I can tell you, and I'll show you in the final slide, that the select board and the FinCom, even though the FinCom has, quote, no power, they do have a lot of expertise, a lot of experience. They will advise, can ask the question, can we afford it, looking out over the horizon. Okay, a big positive, other than the fact that we want to make things better for the people who live in this town, is that we estimate the revenue that we can generate from permitting inspections, what we'll call the nuts and bolts of, I will call, their public health, but they're basically having to do with trying to regulate. And that's about 80,000 per year of revenue that comes in. So if I'm very generous and just do the little arithmetic, again, leaving out personnel benefits, what we're looking for the town is somewhere between 143, and I'll be, very expensive and say 163,000 a year. And I still haven't included the benefits. Pitch that against the 40K per year via the Neshoba group. So that's the background that will raise questions on the part of the public and the part of the committees and commissions and all the rest, who will be very interested and excited about vetting all of this. They're going to be looking at the cost. What's the benefit to the town that makes it worthwhile? Okay, see if I'm sorry about that. Okay, if anyone here doesn't feel the difference is worth it, please speak up sooner rather than later. This is just going to make this a much healthier and better place to live. All right, now, the reason I've left this diagram up is this is based, frankly, on almost, it's not much by comparison maybe of some of you here in town, but this has been my experience over 8 years of working with practically every major board in town. Just to know where I was the chair of the Master Plan Implementation Committee, and most of what you hear about sewers, the train station, better roads, and all the rest, all came out of a major effort on the part of the Master Plan Implementation Committee, basically working very closely, I'm using that euphemism, with all the folks that you're seeing here plus more. Okay, so here's basically the route. The first place that we start, believe it or not, is with the public. And there's no first place. We're doing things nearly simultaneously. By public, that means forums. That means not just ordinary meetings. We may want to put together a forum where we invite someone to join us, hopefully for free, who's an authority in the area of public health, who can speak to the benefits of having a health department, a public health department in our town. It includes members writing and speaking on every venue they can find, but the theme has got to be constant. At the same time, we're making our case as often as possible, as deft as possible with the select board. At the appropriate time, when we have our, as it were, thoughts together, have discussions with both the finance department in the town and members of the FinCom, we can come up with what we consider to be a realistic request for actual costs of executing this. So I want to just pick a number, $150,000 a year, plus I'll add another 20%, and then we come out with a number. That's the number that we're going to be asking from the town. And the first group that has been persuaded of this is going to be the select board and the FinCom. The FinCom generally enters the fray, not necessarily near the end, but about 3 or 4 months ahead of the final sealing of the warrant. So if we're going to be doing this, I think the full meeting is in October, we're going to have to be ready for this. We're going to have our aces together August, latest case September. Okay, so there's a lot of stuff here for us to get done. At the same time, as I said, we're hitting the public at a terrible time because it's summer and we're getting past COVID. Who wants to pay? Well, hey, COVID's a very good calling card for us to use if we are very careful about it. Now, the select board will put its finger up to the wind and try to get a sense of, is this the right time to do it? They will probably never say at the first brush in October, they will probably not say no to us. Okay. The worst case is they'll say, we have a few things we'd like to work on. I'm not saying that's going to happen. I'm not looking forward to doing that. I'd like to get, as it were, get us our person on board for, as it were, next cycle. So that person can work with Jim. So that means they'll be carrying both that person's salary at some point during that year, plus paying the full freight for Neshoba. So make no mistake, this is going to be a not inexpensive transition. So basically, that's what I'm trying to convey to you. This is the nature of what we're dealing with. And the sooner we get to work on our part of it and get our, as it were, our act very nailed down. I don't think we need to get our act together. I think most of us are of the same mind. But some of us are going to have to take on some lifting. I wouldn't say some of us, all of us are going to have to take on some lifting, whether it's being on TV a lot or doing a lot of writing or arguing or making their voice heard. The one thing, though, we cannot do is be inconsistent. If you have reservations, if you have a different emphasis, we're going to have, as a committee, we're going to have to reach a consensus. You may not get everything you want. You may get more than you want. You may get less what you want. We have to be consistent. If we're going to ask for 150,000 and we want to raise it, we do it with one voice. If you don't want to go in a particular direction, we've got to understand what that new other direction is going to be. So with that, I'll be very happy to, answer any questions you have or get further instruction, because my next step is going to be fairly obvious. And that is, I'd like to be able to report not just to whoever the new chair is of our committee, but also report to the select board and others that we have, shall we say, have come together and have agreed we're going to pursue a very structured approach to the transition with the aim of having a Department of Public Health.
Thanks for that presentation, Mike. That was great. You mentioned the numbers that you mentioned. You're including Director of Public Health and a sanitarian?
I'm sorry.
Or one or the other?
Would you repeat?
Sure. in the numbers that you presented, you said that it's the cost of a director of public health and a sanitarian.
Yes, and a nurse. I put everything together
Yep.
so that we have sort of an idea of the big number, because that's eventually what
we would like.
look
Yeah.
like.
Yeah. Okay. All right. Does anybody have any questions for Mike?
I have a question. But again, this is kind of more discussion, I'm hoping.
Yeah.
So
Yeah.
I guess I'm looking at this from a couple different ways. One, I appreciate that it looks like Mike maybe took some of my suggestions in my letter from a few weeks ago, kind of how to approach if we choose to build out our own department. I guess I need to go back a little bit to what's our goal? Obviously, our goal is public health and improving public health, but it seems like we are reinventing the wheel to address what seems to be an ineffective, really, contract management problem. We have a contract with Neshoba to provide the required regulatory and legal services to our community. We pay them a fee to provide those services, and it sounds like we're not getting the feedback, the information, the closing the loop piece that the board in the past has felt has been required. And I would agree that it needs to be required. So it sounds like basically we have a contract that is either not built correctly or not being managed as effectively as possible. So it sounds like the choice is getting rid of the contract and starting over from scratch. And if that's the case, that's certainly something we can look at. Is it possible that, we simply try to enforce the contract so that we get the services we expect and are required and the information to make sure that those negotiated contractual obligations are being met by Neshoba?
I'll let you answer that, Mike.
Do you want to cover this or what?
No, go ahead. You know this.
Okay. Okay. The simplest answer is that as much as I might be inclined to start from scratch, as it were, what's happened as a result of not starting from scratch on day one, which would be if the approval gets through town meeting in June, the bill has already been paid for fiscal year. So in other words, we have Neshoba for the next year, whether we want them, where someone doesn't want them or not. Okay. All right. The second is that it is not clear enough given the fact that the process of vetting the proposal or the idea of going to a public health department has not been vetted by all the interested government folks who have authority over how money gets spent in the town. I'm looking at the select board and I'm looking at town meeting. We started the process, shall we say, early enough, you would think. However, given where the select board is now with all the other stuff that they're looking at, I'm not saying they delayed anything. It did not go through FinCom. They were sort of taken aback initially by the numbers. Their thought was we just put Neshoba aside and just brought someone else in almost at the same price point. The notion that we were going to pay more was a revelation to some people. The visibility of the Board of Health in doing this changed dramatically. It became more of, this is a meaningful step. I don't know if we're reinventing the wheel, technically speaking. I also can tell you that as a result of what went on, Jim has agreed, number one, to basically, he's added one additional person to his staff based on a grant he mysteriously came up with from the state. And I'll be very happy to go through what's going with the state in a minute. So he agreed several weeks ago in a conversation, detailed conversation with Lisa and myself, because I knew this was the right time. He agreed that he was going to hire an additional sanitarian that would cover basically those instances in which he couldn't, as it were, hit the mark on the inspections and permits and that kind of activity. what I call the septic, the septic related activities. Okay. As far as the other functions are concerned, the really concerning is that, very frankly, the operation is not going to be as opaque as it has been. It's been agreed that we will receive, as it were, immediate email documentation of every permit request and everything else that comes into the office at AIR. Because right now, everybody who asks for something from the Board of Health or needs something, they go to the AIR. In effect, they do AIR office. We don't necessarily log it, see it, or do anything. So now something's in place, or at least promised in place, to have that come back. All right. But this is fairly important because all I can tell you is that when I went to look at what revenue was being generated, who was doing the work, and why weren't restaurants being inspected, and I don't want to, I mean, it's a whole list of things. None of them were malicious. There was just nothing there. Okay, so we're asking for an accounting, and it was admitted that they are now, Jim's group is going to admit to accounting. Their operation is paper-based. They have file cabinets and paper, which is reason number 9 I have personally of wanting to have a real Department of Health. I think it's very important that we have records, data, numbers of who's doing what and why they're doing it and what's happening to people in our town. I don't know, Dan, if that answers your question completely, but we can't move until certain police. And by the way, our town hall is not yet ready as to do what I would call point of sale.
And I'll just add one more thing, is that we have been fairly happy with Jim, but we're growing and he can't offer us any more services than he already is giving us. So we decided that, somebody dedicated to Littleton is something that the town should really have. So.
Okay, so I kind of go back to my original question. It really looks like we've had ineffective contract management oversight, that we contracted out the services and there's been really no oversight and the SHOBA hasn't been held accountable to document the services provided for the taxes we paid and the services we paid to them. So that being said, we are then there looking at either holding them to the contracted agreement, you will, as agreed, or we in fact start from scratch with our own department, our own process, our own vehicles, our own software. We start from scratch, which is an option. Certainly when we talked to Mike Hugo last week, that he said this was atypical, particularly for a small community, to go it alone, for lack of a better term. Certainly, as we recognize, the cost of $200,000 plus benefits and either vehicles for a director and a sanitarian or mileage is going to add pretty quickly to that number, and it will only go up moving forward. I'm just trying to figure out how do we be most successful? Is bringing this completely in-house with 3 staff when we're looking at departments who are watching that bottom line every minute these days here in town? Is that the best way? Is it basically recreating the SHOBA, start from scratch by recreating the SHOBA, but with partnering with another local community, whether that's Ayer, Groton, Acton, whatever? But do we start from scratch, which is atypical at this point in Massachusetts? Do we recreate the Neshoba wheel, but on a smaller scale where we share costs, but perhaps have higher services from a small team who we're sharing? Or do we hold Neshoba accountable to do the job that they've been contracted to do?
Well, again, all I can tell you is that if you look at the amended services dated 2019, which is the last one I think that exists where the service list was updated. The listing is sparse and very frankly doesn't cover some of the items maybe that are of interest to this board. I don't know what all the interests of the board have about being a more effective shall we say, Board of Health and Public Health operation. So I don't know, I'm not sitting here saying, oh, it's a bad idea to do cost sharing with nearby towns. I think it's a great idea if, and the if is, what are we doing, as it were, to accomplish our goal? From what I can see in the way it's structured, when we directly asked Jim to hire an additional person just to cover the sanitarium functions, with the purpose of freeing him up more to cover what we'll call more programmatic, more preventive programs, okay? He didn't have, they're not structured, quote, we're not structured to do that. That's a fancy way of saying their business model doesn't work that way. So that was the first thing. That's who they are. That's who they want to be. And because he obviously answers to just more than Littleton. When you have someone shared, you're sharing them. They're not your person. The other thing we have is a memorandum of understanding, which in my view is a bit one-sided, where basically Littleton agreed under this memorandum of understanding that he will make a best effort to carry out the services. But that best effort is going to be limited by time and resources he's got.
Can you share that 2019 list on the memorandum to the board so we can see it?
Sure, I can. I mean, it's public record, but I'll be happy. I'll send it on to. I think Lisa has it. You have a copy of it, Lisa, don't you? I think I sent you everything.
Yep. I was going to say it should be record. Janet should have a record. I mean, if this is a memorandum and a list of services provided by Neshoba to the town,
yes, in 2019,
it should be on file in the Board of Health office in Town Hall. So Janet should be able to have a copy of that pretty easily.
Janet, can you get that out to everybody?
I thought in one of the meetings I had it made available to all of you, but apparently this predates you, Dan. I'm sorry.
Nope, that's okay.
I think you're now into what I would call, what is it we want to do?
That's exactly where I'm trying to get to, is what is our ultimate objective? Beyond, obviously, providing the best services for the health and safety of our community, it is, are we looking for meeting our regulatory responsibilities with accountability so we can document that we are in fact meeting our obligations? Are we looking for the most cost-effective way of doing that? Are we looking for control and authority over all aspects of that, which is certainly a possibility? It really is, if our goal is, I think for all of us, we really need to figure out how do we accomplish the goals, preferably go beyond just the legislatively required goals, while also maintaining some fiscal responsibility.
That's exactly what I said in the go through, Dan. I'm glad you're echoing it, because we're at the point now where we have to get ourselves in a position where we can get together and have what I would call an informed discussion about the various paths, routes. For example, if we decide or have good reason, not good reason, if it's decided, for example, we want to share, if we want the accountability, if we want to basically be fiscal responsible, we have to get all those things aligned. And that we can't do tonight, I don't think.
Go ahead, Kevin.
Mike, thanks for the presentation. I think that was very well done. I appreciate you putting that together. I think as my opinion, as a member of the Littleton Board of Health, I think we should strive to get as close as we can to becoming an accredited Board of Health and providing the 10 essential public health services. I'm not going to go through the list right now, but I can send them around for everyone to comment on. We would never get there by working with Neshoba. They're spread too thin. There's not enough resources. There's no systems. Regarding systems, Mike, POS, point of sale, I did speak with the building commissioner, and he said it'd be fairly easy to implement via the open gov vision system that the building department works with now. So he said he was able to create some forms. Hopefully we can have a look at those and see if that's going to be the right system for us if we choose to go this route. I think your number on the fees is light. I think the 80,000. I think we can generate more than that.
Well, it would be lovely if we had a record of what the fees were.
I got the back of the napkin version that Lisa sent, but
No, but I actually, never mind. The number I generated is actually from what is extractable from the record.
what you could find. Yeah.
Yeah, I mean, it's record keeping is not one of the strengths here.
How long have we been with Neshoba? Does anyone know?
Well, there's a record of it that goes back to almost over 35 years.
Oh, wow. And our population was 200.
Yeah.
I just think the town's growing, and it's time for us to,
Yeah. And I think the pandemic has shown us all that we need to have a bigger role in public health in town.
Yeah, but I think Dan has a point. I think that
he does.
There's a lot of this is a fair sum of money when you. I mean, I didn't include mileage simply because I don't know what the mileage is. I mean, getting that out was life's work, and I do have other things to do during the day. So I had to, all I can tell you is that the financial aspect of this is pretty obscure, and we're going to be very fortunate if this year if we get our hands on some actual flow, and it's going to be somewhat distorted because of the recovery process from pandemic financially.
Right.
Would it be helpful to put together a sample fee schedule to present to the select board and FinCom, and along with some sort of job description for the?
Well, right now the fees are set by Neshoba.
Well, no, but what our own would be.
Their fees. I checked them against what's around us. Even the bigger towns with so-called muscular operations, they're not off that all that much. I'm just telling you. I mean, we should look at it. Maybe, Yep. No problem.
All right. So you think we what would you suggest like next step? Who
Well, at the risk of I don't want to put people on the spot because it's not an agenda item, but I would like to indicate that at least informally to the select board members who are inclined to support our operation or move forward, that we are going to actually work on this. As a board. I mean, it's not going to be, it doesn't.
I personally would support that.
It's going to be asking people to volunteer or whatever to take on certain tasks, especially those that feel that they've got a special insight or want to learn more themselves.
all right. So continue the discussion, or do we have some homework to do?
Well, I just like to know if this is not a vote. I just like to know, is anyone sitting on the board who feels first of all, that they feel that going through this process of getting ourselves ready to move forward, which includes discussing not only what Dan and I have been, as it were, spinning here, is there anyone here who doesn't want to do this, who wants to stick with Neshoba after all, and regardless? I hate to put it so graphically, but that's sort of where we are.
Yeah, no, I'm fine with moving forward.
Yeah, I think if we could get what we need from Neshoba, I think that probably would make the most sense. But if they are unable or unwilling to provide what we need to be in compliance with our responsibilities, then I'm not sure I see another choice.
Okay, the other thing I'd like to have, with the board's permission, because I don't like to invade privacy, but would it be possible for me, unless you, Lisa, or whoever wants to do it, discharges me from for doing anything here? I'd really like to have the contact numbers for our board, not for policy discussions, but basically to enlist and get information primarily.
You have my contact number.
Yes. It's Dan, it's you. But I don't like to feel like I'm picking on you because you're new.
That is perfectly fine. I'm happy to share my phone number by email. Hope you don't mind. I'm not going to put it over LCTV as much as I love talking to
don't.
other residents.
No.
And of course, just, as always, we will be very, very clear and careful that we are not violating any open meeting violations with discussing things, even if it's serial conversations from Mike to Gino to me that would also be a violation. So
no. That's
for the public out there, we will be very cognizant of those discussions and make sure there are no deliberations involved.
Mm-hmm. Yep. All right. Is it our? I think our contact information is on the website, isn't it? The town website. Not sure.
Your emails are, but not your personal.
I really only need email basically to say hello. That's basically it.
All right.
And you have that, Mike, on the Board of Health emails that I send to all of you at the same time.
Right.
Dan,
I just want to make sure that it's okay with folks that no policy will be discussed. You can't do it anyway.
All right. And so what should our next step be? Do we have a joint meeting with select board or FinCom, or do we just still gather?
No, we're some distance. We're still a few weeks and months from that. I can certainly propose, I think it would be presumptuous of me, given the fact that we have fairly experienced people on this board, of what they feel most comfortable about as a next step.
Does anybody have any ideas what they'd like to work on next?
I mean, this is be a joint activity at a meeting that we're having with definite goal, we're trying to get something done within an hour or whatever.
Yeah.
The elephant in the room, it's going to come down to finances. So I think that if we can put together a pro forma with a fee schedule and potential activity based on what we know about what's been happening. I know, Mike, I know there's no data. But there's got to be a way that we can work with the building commissioner and folks. Janet could probably help us significantly. I'm sure there's, all the permits, there's got to be a way in the office somewhere to see what's been happening.
Okay, I want to just step to the right or left, I'm not sure and see if I can get more activation here. I like Dan's idea for a number of reasons of having some serious chats with Neshoba to follow up on previous serious chats.
Mm-hmm. Okay.
You want to follow up on that, Mike?
I'm making a suggestion. I'm looking for people to say the hell with you or something back.
Not at all. No, I think the continuity with you.
Was I muted? I'm sorry. I'm all for it, Mike.
Okay, so I'm sorry, Dan, please, you're unmuted, so please.
No, I was just going to say, I do not know our history with negotiations, seeking of information from Neshoba. It sounds like it's been a challenge for some time. I don't know how often, how aggressive, how long, how far back we've gone. We've kind of asked them the same question, trying to get the same information. I simply don't know as a new member of the board. So I think that's kind of that piece of, is it going to be successful? I don't know. I don't know the history, unfortunately, that piece. So,
well, I'm unaware of any. There's very little report. There's very little history. The history is approximately 4 months old. So
the board hasn't been particularly active in its oversight and communication with the board, with Neshoba.
Thank you for summarizing.
Well put.
I'm just trying to understand it, trying to bring it all in.
Let's put it this way. I don't bring a bat to the negotiating table. I bring a manila folder, which I fold up and leave. Okay.
All right, I think that's great, Mike, if you want to grab some more information from them and.
Okay.
Yeah. Okay. Okay, Kevin.
Janet, I was wondering, do you guys still have that that cash receipt booklet? When someone gives you a check, you write it down in the carbon copy book there.
No, it goes. I have my accounts. I've got the accounting documents of actually turning in the checks, though.
Would that be helpful, Mike?
Where I'm going, no.
Okay.
I mean, at the moment, no.
I mean, a big
Also, there's a whole thing going on at the town hall, because on the warrant there's a basically creation of a new department that we just have to inform the Commonwealth about it, because we're forming a new department. Not we, the town is forming a new department called Land Use, which has inspectional services and other things, as well as administrative structures.
I'm just reading the article. It's called Select Board Land Use Department to see if the town will vote to establish a land use department or Department of Municipal Inspections. So. Okay. Continue the discussion next time. See what Mike digs up.
I was gonna say, Mike, if you need backup when you talk to Shoba, let me know and I'll do my best to be available.
Thank you, Dan. Appreciate it.
All right. Any questions or anything for this discussion anymore? Okay. Move on to the discussion of reorganization of the board. So I think we definitely we don't have a vice chair right now. And I don't know if anybody wants to.
Right. I'll start things off so you can start throwing pellets. I make a motion for nomination of Lisa Flanagan to be chair. May I do that, Madam Chair?
Yes, you may.
Okay, make a motion that nominate her for the position of chair for the for the year.
Second.
Thanks, Kevin. Take a roll call. So Kevin Baker.
Kevin Baker, yes.
Gino Farloni.
Yes.
Dan King.
And Kane, yes.
Great. And Mike Zeldin.
Mike Zeldin, yes.
And I want to nominate Kevin to be the vice chair, if you're all right with that, Kevin.
Good.
A second.
Oh, I don't know. Maybe I can't do that. Can I not do that?
You're the chair.
I can't do
I
that.
don't know.
Can I? Does anybody want to
Chair can
nominate?
make motions.
Okay, so I want to nominate Kevin to be the vice chair.
I second.
Okay, and roll call, Kevin Baker,
Kevin Baker, yes.
Gino Farloni,
Yes.
Dan King,
Dan Kane, yes.
Mike Zeldin,
Yes.
Lisa Flanagan, yes. All right, my first motion every other week. No, we'll kid. We'll kid.
Still have clerk.
Could I ask a question,
Clark?
Madam Chair? Do you
No.
does anybody want me to continue with the quintessential title, Clark?
Clark?
Clerk.
You mean the clock?
Clark, yes.
I'd love for you to keep on doing it, Mike. You've been doing a great job with this, and I think, like I said before, the continuity of you sticking with it is what will get this through. So
I just want to be able to, as it were, make sure that they have as much muscle at the table needed as possible.
Yep. So do we need to nominate him again, or do we just?
I think you just did. We need a second.
I'll
All
second.
right, great. I'll do a roll call. Kevin Baker,
Maker, yes.
Gino Fratelloni,
Yes.
Dan Kane,
Dan Kane, yes.
and Mike Zeldin.
Mike Sullivan, yes.
All right. Anybody have any correspondence?
I do.
Go ahead, Dan.
All right, one, unfortunately, Chief Budzinski left, but this is National EMS Week, Emergency Medical Services Week, a position near and dear to my heart. So I just want to take a moment to, one, thank our police department first responders who respond to almost every medical here in town, as well as our fire department EMTs and paramedics who respond obviously to all of our emergencies 24/7, 365, but also are often our first responders for public health issues. They were the first to recognize trends at Life Care of something was different than normal, as well as identifying elders at risk and connecting them up with Elder and Human Services. So they are often our first eyes and ears for public health here in town. So
Yep.
recognizing our EMS folks from the police and fire department. The other piece I have, I had a resident ask me a quick question that probably does not fall under our responsibilities, but I'll read it since I didn't share it out to everybody. From the resident, I am not certain if this is a conservation initiative or Board of Health. It's time to get the porta potties back at the trailheads. I shudder to think what people are doing in the woods. Bathroom rights are human rights. Thank you. So I don't, obviously, while Mass General Law does in fact allow boards of health to establish sanitary facilities within their community if they choose to, I don't think this is something that the board has probably done in the past. It's probably been either conservation or Littleton Trails, or the trust. I just don't know, but it's been brought forward. So maybe we can, with COVID, I think a lot of things that had traditionally been done weren't done last summer, and having everyone kind of get back into that piece of, oh yeah, you do usually do that. We should probably get those things up and running again. I'm just not sure who that would fall under and how best we can share that out.
Sure, I can get in
Probably
touch with-
whoever has the money that paid for the porta potties.
Well, but it's not like someone has in the past, so it means somebody has a system to make that happen. We just need to figure
Yeah,
out who that is and let them know.
Yeah, I can get in touch with Alicia at Park and Rec and Conscom and see who's responsible for that. I think
That'd be
I've spoken to Alicia recently. They've just changed providers of the porta potties for Park and Rec, so maybe those people need to be informed that they need them at the trailheads too. So.
All right, awesome, thank you.
So now to member comments. I guess we're still waiting for a room, Janet, for meeting in person again. So nothing.
No, based on the town meeting, the staff meeting we had the other day, it sounds like a lot of boards are just waiting until September or October when we shift. We'll be moving into the old library as a department, and there'll be more meeting rooms in there.
One other quick comment that I had, I spoke with Chief Bernard last week regarding Mike Hugo's question about the homeless problem in Littleton. There is none. We had one gentleman who was homeless a few years ago, and the town was able to find him a place to live. So there is no homeless in Littleton. So,
Madam Chair,
go ahead, Mike.
I'm sorry. It slipped away. I apologize for this. Is sort of out of order, if I may be permitted. There was an express desire to bring whatever we do to bring it in so that we're in compliance with the 10, shall we say, tenets of the CDC for basic public health. According to a 2019 survey, study, and analysis carried out by a very large board of many people in public health and in public life, it was concluded that, like the rest of the United States, we have many, many boards of health, but practically none of them, with the exception of 2 or 3 in the country, in the Massachusetts, have reached the level of being, shall we say, acceptable at the CDC level. Boston is one of them, to give you a clue.
And Worcester.
I'm not sure about them, but all I know, there were 3 back in 2019, and there were none others. And around the country, that's also a major problem. Public health is one of the most underfunded operations, big surprise, in the whole country. We have a special problem here because we're so fragmented, of course. That's what we're doing. So sorry to interrupt you. So I just want to make sure that, that we understand that our desire is basically not necessarily unique, but struggling for dollars is going to be really tough.
Any other comments? Okay. What do you guys think about after town meeting going to every other week? Or do you want to just play it by ear and see how we're doing with our progress?
Town meeting's on June the 8th. Is that right?
Is that
I don't know.
town meeting is the 12th?
12th. Okay.
Yeah.
So you would wait till after the 12th to do it.
Well, I guess we don't. I mean,
I think we could probably reduce the COVID updates.
yeah,
What do you think?
yeah, probably to every other week or something like that. I mean, if we meet every other week, I guess the COVID will be hopefully getting low if we're meeting every other week too. Or do you want to just do COVID, alternate again the public hearings? We have a lot on our plate too.
Janet, you're muted. Oh, sorry. You're talking to us.
All right. Well, we'll just meet again on the 16th, and we can keep on thinking about this.
I'm sorry, what's the date? June 16th?
Actually, I'm sorry, I'm on the wrong date. The 26th will be next Wednesday. So if it's all right with everybody, let's continue to meet every week until we come to an agreement and we find out how we're doing.
I just had one other comment.
And I'm sorry, like you said, maybe we can start reducing the COVID updates.
Yeah, because Katrina won't have to do it for the schools. I don't think, right?
Right, yeah, because schools are going to be ending pretty soon, so there won't be any pool testing, and there won't be any. Right. Her presentations will get shorter anyway because of that. So.
And the information is obviously really important, but it's what action would we take based on the information? Are we going to be changing our practice based on what we learn? Unless there's something dramatic, which we all hope doesn't happen, we're not going to be instituting a new mask mandate for Littleton. You know, if we see something, our actions are going to be limited, so it's asking a lot of heavy lifting continue from her when we're probably not going to take any actions based on her work. So.
I just had one other comment before I forget. Mike, I was wondering if you had some sense of a timeline, sort of a checklist, a guide for us to go through the process of developing this department so that we can just make sure we stay on task. And maybe once, when we have our meetings, we can just say, hey, how's this piece of it coming along? Or, Gino, you were assigned this task, did this happen? Lisa, did you do this? Whatever, just to manage the process a little bit.
The best way I can answer is that I don't think I've been charged with responsibility. Maybe I misheard, but I'm not sure I've been asked here to design a Department of Public Health. I don't have my background training is not in that area at all. I mean, I can tell you about the molecules that make up a director, but not what he or she should be doing.
No, just a timeline for actions that the board has to take.
Oh, I see. Okay, that's a little different. Now I understand.
Target.
Yeah, I can come up with a battle plan for
something like that.
Moving ahead, because we're going to be battling. One front is already opened.
Time is not our friend here, I think.
What?
Time is not our friend here, I think.
The one front is open. That is a serious discussion yet again with the Neshoba. And the other piece is obviously putting together the major item now is to basically plant more seeds with the good seeds with the select board.
And Janet, so you guys all set? No more member comments? And any public comments, Janet? Anybody have their hand raised?
Yes, Christine Nordhaus has her hand raised.
All right, Christine, state your name and address, please.
Christine? Hello? Christine?
Okay. All right. Is there anybody that wants to make a motion to adjourn?
Make a motion to adjourn?
Great. And is
Second,
that you? Was that a second, Dan? Kevin Baker,
Yes.
Gino Fratelloni,
Yes.
Jane Kane,
yes.
Mike Zeldin,
Yes.
and Lisa Flanagan. Yes. All right. See you guys next Wednesday.
Yeah.